Hello, my name is Lexi Salazzo, and I'm going to be doing a presentation on the ethical considerations for gender nonconforming youth. So I want to start off by looking at sex versus gender, and to note that sex is a biological construct, and therefore it's something that the individual was provided at birth. It's their natal sex, and when they are born, they are given this identity as opposed to choosing it. Gender is a social construct and something that I'm looking more closely at today. And it looks more at the attitudes, the feelings, and the behaviors of this individual's culture or being. And I think that gender expression is a really important word here to understand the population and just how they choose their gender role or their gender identity. These types of identities can also be known as gender nonconforming, gender fluid, gender queer, transgender, gender questioning, and gender neutral and genderless. I think it's important that depending on the individual, they're going to have a different way of identifying, and that certain things could mean they do not accept the male-female, or that they're finding something that best suits them, or that they are not choosing a specific identity that they would like to conform to, so maybe one of these that are listed below doesn't even apply to them. So it's really about the expression of the individual and what they feel will allow them to have the same internal as external kind of emotions and feelings. I've included the genderbread person because I think it gives us a spectrum of how we can understand how, especially an adolescent, might identify, because there's various levels that kind of influence that. There's our gender expression, there's the way that we are biologically born, and then there's the identity that we kind of pick, and I think that it fluctuates on this spectrum of male and female, woman, man, but I think that it's so fluid now. And that is the population I'm really looking at, are the individuals that are kind of developing a sense of who they are. Because when we think about adolescence, we're thinking about this identity development stage. So again, I really like the term that Pine 2014 used, and it's this gender independent youth who was looking to really push the boundaries of what society has kind of delegated as man, woman, boy, girl. And it looks at the individual's unique gender expression, their culture, how they're accepted by loved ones, friends, family, support systems, and how that could impact them, because there are positive and negative influences that will occur. And sometimes those things can increase self-esteem if it's positive. It can increase their ability to identify. And it can also be negative. It can increase levels of suicidality, depression, and anxiety. And it's important to think about an adolescent because they're still being helped by their caregiver. So I then have this model about how a caregiver, a family system, might react to an individual who is going through this crisis or this this journey of developing. It depends on their journey. And so we're looking at the discovery, so identifying what's kind of happening now and labeling it, and then the turmoil. So a lot of parents will actually feel as though they've lost their child, the identity that the child was born with. It can be as far as, I feel that I've lost my little boy, I've lost my little girl, who is this person? And that can contribute to a lot of mental health concerns, which I think will come up later ethically. And then negotiating, so the family coming together and really working through whether or not they accept or do not. And then finding balance again. And looking at the treatment, I think it's important to look at how identity development comes up, because they are adolescents, therefore they are in a span of rapid development that is biological, cognitive, psychological, psychosocial, and much more. Looking at their support systems and how they might interfere ethically in the context of therapy, and seeing how things like suicidality and different other labels might come up. So some really pertinent ethical concerns here are the parent's impact on the child's therapy. So because we're looking at adolescents, I want to focus specifically on those under the age of 14, because the parents still play a really dominant role in their therapeutic alliance with their therapist and just the course of treatment. And sometimes parents will recommend their child for treatment, and it's because they think it's just a phase. So bringing that into a therapeutic setting, whether or not the parent is involved in the therapy themselves, you have to begin to question what is taken into account. Is it the child's voice or is it the parent's voice that's being heard? And it might be a premature recommendation for therapy, and the child might not be ready for therapy, which is ethically incorrect, because sometimes a child is too young cognitively to be able to do such, and they might need to wait, or maybe the way that they're developing is just natural in a course of development. Granted, I think there are therapists that can, and we know as creative art therapists that there are ways that we can attune to any age group, but I think that sometimes therapy can feel as if the individual doesn't have a voice. And then for the individual experiencing therapy, they can feel a severe distance or ostracism from their family and friends and how that comes up. And I think that plays directly into suicidality because as clinicians, we are responsible for reporting things, and a lot of the times when a child is feeling alone and feeling isolated and feeling as though they don't know what's going on, it's complex and it's overwhelming, they kind of seek out these means of either harming themselves or ending their lives because it is too overwhelming. And along in the article that I was mentioning earlier, there was this idea that individuals going through this in more of a crisis mode are actually experiencing it as if they were being abused or neglected by their families. So then further you're looking at the treatment refusal as well as labels such as body dysmorphic disorder, and is it the person's process or is it a label or is it a diagnosis which is accurate? How much can the therapist understand and trust if they're being given information from the adolescent as well as the parent, so validity to consent, a multicultural perspective, just taking that into account, and then disclosure, again, because of their age. So my case vignette here is about Casey. He's a 12-year-old Caucasian male. Casey is identified as a male at birth, but is currently feeling that he fits more so with female attributes, and he enjoys dressing like a female, he enjoys makeup, he enjoys dancing because he feels it's somewhere he can be accepted. And Casey recently has had some conflicts with his parents. They're really not sure what this particular behavior is, and they're concerned, and they're wondering where their old Casey is. The problem, or the admittance for therapy, was that Casey's father, who is a military executive, walked in on him trying on his mother's dress, and that was concerning to Casey's parents, and so they admitted him to therapy. But along the course of therapy, Casey did report to his therapist that he was feeling depressed and had ideas of harming himself and ending his life. Casey is 12 years old, so take in consideration the age of consent and confidentiality. And Casey's father did ask if he could have some information and better understand what's happening with Casey in therapy. And Casey has asked that he doesn't want his parents to know anything, but this is an issue of life or death if he's feeling this way. And Casey's father has advised this therapist that they should start to begin to talk about body dysmorphic disorder because he does believe that Casey's predicament is just a phase. So the ethics codes that I looked at here were informed consent, respect for confidentiality, minimal disclosure, serious and foreseeable harm, responsibility to parents and legal guardians. So basically we're looking at what is the role of the parent, what is the role of the adolescent, and how does that interfere or support the role of the therapist. Trying to understand how much does the therapist need to tell individuals and how much does the therapist keep within the therapeutic setting, because Casey, if we're applying it to his case, is at risk now for self-harm, and Casey's father is asking for some disclosure to be had between him and the therapist. But it is the therapist's job to respect Casey's wishes, to respect the client, do no harm to Casey, meaning that they're providing the best services to Casey, and ensuring that the therapy is directed towards Casey's needs and not his father's needs. And so again, we're looking at Casey and his father, as well as his mother and the therapist. And again, we're making sure that Casey is being heard and understood by the therapist, and that it's more of him trying to find his identity versus him needing a label or a diagnosis. The codes reviewed were the ones in the slide previously. Some of the principles that we're considering here is ensuring that we are doing no harm to our clients and that we are providing them with the best services mentally and physically, and doing no harm or emotional harm. Thinking about how this might, if I were the therapist, I think that I would have some bias towards dad because I maybe don't agree with that. And then looking at maybe bringing this to supervision and moving through it with some colleagues. And I think if we bring it onto a movement level, we can better understand the socio-cultural context. And I believe that a goal for this, and when we're weighing the consequences, is thinking about what Casey's goals are versus what Dad's goals are, and maybe bringing them in together in unison in a therapeutic setting and working through how they can better communicate and how Dad can better understand Casey. And together they can reflect on that through movement or through verbalizations. Overall, I think that it's really important that when we're thinking about the course of action here, we understand that Casey was the first one, the primary student, to be admitted to therapy. And even though Dad is potentially paying for therapy and was believed that he wanted Casey to go to therapy, the student that's in therapy, this adolescent that's trying to figure things out, we're really looking towards what he would like. And because his life is at risk and he's brought these issues up, I think that the therapist and him have to have a plan and come up with a plan where they can talk about it and ensure that Casey is being safe and he's safe at home and others are aware so that he's not alone, and then he can begin to kind of tackle other experiences or issues that he feels are really detrimental to his developmental process right now. And that is where I'm going to go to my discussion, is again honoring who Casey is. If Dad sees him with this body dysmorphic disorder, are we really seeing Casey for who he is? Or are we seeing the diagnosis over this person? Because we really want to be person first. We want to be person-centered, so seeing person over diagnosis. Again, this is important for adolescents because they are all going through this identity development, and therefore it might not be that they need this diagnosis, and it might be a phase, but no matter what, we're understanding that cognitively and emotionally and physically and all other levels of their life, this is an appropriate time for them to develop and question what's happening and make choices. Also looking at parent attachment styles, depending on how Casey and his parents have developed as a family and through either secure, avoidant, or dismissive attachment, whatever it may be, we have to understand that that is also part of their family's culture and honoring that in the therapeutic setting, because we do have to honor our clients' cultures. That is our job ethically. Looking at Casey's age, again remembering that he is 12. Some adolescents will be older, but this is important to recognize that Casey really isn't alone in this due to his age. Looking at what the true stressors are. So what is happening at home, what is happening in Casey's social life. I think it's important to look at stressors because sometimes that is where our role comes in, and we have to consider what is happening to the individual and if that's ethical out in that individual's world. Looking at coping patterns, I think that's multicultural as well. We're looking at how a family has taught the individual to cope and how they're coping in a therapeutic setting, and ensuring that the student is getting everything that they need and that it's appropriate for them. And then the type of therapy. Is it family-based? Is it individual-based? Is it child-based? I think that's really getting to who you're serving, how you're serving, and where your boundaries lie as a therapist, and making sure that you don't cross those boundaries so that the family can be collected in a therapeutic setting, but so that the individuals that are seeking therapy and creating these treatment plans and goals are being heard, and their perspective and their unique worlds are being honored. And so overall, I would like to say that I think it's really important that we understand that clients, even at the age of an adolescent, have a voice as well. And for someone like Casey, they're really going to need this support and need to be fully heard and understood by their therapist. And that's where we have to set our boundaries and our walls in between parents and child, and then we can begin to tackle the issues. And there are my references. Well, thank you so much. All right, bye-bye.